Gopal, and he'll be speaking on extremely disturbing postoperative floaters. We have all had patients complaining of floaters, and on suboptimal visual recovery in a clean postoperative case. What next? So, Dr. Gopal Pillai.
Is the mic on?
Yeah.
So first on, we will talk about troublesome floaters. Cataract surgery is no longer a rehabilitative procedure. It's a refractive procedure in which nothing short of 6/5 is acceptable. So there's a very high patient expectations, and vitreous floaters caused by degenerative or pathologic alterations in the vitreous is perceived as flying objects around the eye, and they are very disturbing. So symptomatic visual floaters, they don't actually alter the visual acuity. Visual acuity may be 6/6 or 6/5, but these things will be floating around, and it is a very, very common cause for patient dissatisfaction. There's no very well-defined consensus of management. One may be that it's a pre-existing floater, and a pre-existing floater in the presence of a cataract, which actually dims everything, would be not so visible pre-operatively. But once the cataract surgery is done, and now the patient's vision is very clear, these floaters becomes visible and more disturbing. Secondary floaters are intraoperative by leakage of lens matter or OVD or air bubble, or if there is a PC rent or some problem like that, or a postoperative PVD, or a degenerative vitreous syndrome, or even a retinal break or tear can also cause it. So these are the different causes. Some personality traits like type A personality perceives these floaters. Generally, all of us, what we would say is, okay, this is nothing, this would just go away, you just ignore it, it will go away. But these type A personalities find it very disturbing, and they would not tolerate such a floater. So high dissatisfaction is there, and obviously yes, there will be some scattering of lace which causes contrast sensitivity to be diminished in these people, and strong positive correlation is detected between quality of life and a qualitative ultrasonography to actually look at quantitative ultrasonography to look at floaters. So ultrasound scan detects these floaters, but we know that a PVD in an older age can produce some of these vitreous floaters, and many of them don't complain of floaters. So OCT can also image floaters. SLO, both the umbra and the penumbra caused by the vitreous opacities can be visualized. You can see this is an ultrasound on the left, which you can pick up the floaters, and you can see that in the OCT also some darker areas may be seen. The darkest are the umbras, and the surrounding grayish halo is the penumbra. So history taking, basically this patient may have a retinal detachment, prematurity, or arthritis, or midline defects or something like that. A complicated cataract surgery with a postoperative notes or intraoperative notes may be there. And a fundoscopic examination should basically target and exclude inflammation, because vitritis is a first sign of endophthalmitis and pars planitis or something like that. So rule out inflammation, which is actually a reversible cause of floaters. And then if it is something like asteroid hyalosis or vitreous hemorrhage PVD, so depending upon the type of floaters, you can decide whether it is a reversible or non-reversible, and look for any peripheral breaks. So quality of life, definitely you can ask, and clinically significant persistent floaters, you can either observe, or conservative management, you can give some placebo drops, or you can consider intervention. So choices of intervention would be, one is phlotrectomy, which we don't advocate, but there are certain patients who are very persistent, very large floaters, in which we can definitely offer that. And Nd:YAG vitriolysis is the other option which is there, acts only on the collagen component, you can do that. So phlotrectomy by MIVS, definitely there's those patients whom I have done, they have significant improvement in their visual acuity. Even though the vision was 6/6 preoperatively and postoperatively, the quality of vision improvement is significant. Nd:YAG vitriolysis I have not done, so I think it may be a little more because we are the control on the vitreous is a little less, and I feel it may aggravate certain problems later on also. Pharmacological vitriolysis is another thing, hyaluronidase or vitreous, or the newer drug which is coming in, urea, all those things which can be there, but not approved for symptomatic visual floaters. Then International Survey of European Vitreoretinal Society floaters, they published articles, retrospective survey, overall satisfaction about 476 out of 581 patients, a lower presenting with smaller opacities. and that is safer when core vitrectomy and cut rates were done. No significant advantage for more than 4,000. So in conclusions, there is no single consensus. You need to personalize, and proper case selection is important if you want to do flotrectomy, and identify the well-suited cases, and risk benefit ratio, because if there are a lot of lattices, if there is a history of retinal detachment, it is better that we wait. If there is nothing like that, if it is an old patient, already PVD is there, it is a easy surgery. Thank you very much. Should we go to the next presentation? Are we short of time?
No, no, no.
Yeah.
Just rush through the presentation.
Yeah. So the second talk would be a suboptimal visual recovery after a clean case which is seen post operatively. So we should basically look at, in this talk, we will look at what are the reasons. That's the only thing we need to find out the reason. And we should find out what can be done now. And then more important than that also is how to counsel the patient and documentation, because these are problem cases. As I said in the beginning, cataract is no longer rehabilitative. It is a refractive procedure which requires 6 by vision, and nothing less than that is acceptable. So preoperative evaluation, we will always look at, is the cataract commensurate with the visual loss? But sometimes when it is a white mature cataract with very poor vision like hand movements or PL, you have to rely on the pupillary reflex if it is good. Or so pupillary reflex before dilating the patient is a very, very important measure, and it gives you a very simple evaluation of the overall visual potential of that patient. Now, if the retina was visible, is the retina, optic nerve, the vitreous, everything, is it normal? Are there any floaters, like we said in the last case? Are there any preoperative history of any stroke or something which can actually jeopardize, or CNS problems which can jeopardize the vision once we do the cataract surgery? That's very important. Now, preoperative pathologies are often there, like high astigmatism, which definitely all the cataract surgeons would definitely look up, because an IOL power calculation would be done. Glaucoma, maybe it was missed preoperatively, but but glaucoma can cause obviously a lot of damage. Floaters, in during cataract, through cataract we may not be able to assess a lot of floaters sometimes, and that is sometimes missed. Macular and retinal pathology, so macular hole, diabetic macular edema, AMD, any scar, any choroiditis, any problem that can occur in the macular hole, any problem that can occur in the VMT, mild VMT, which can actually progress after cataract surgery. All these macular and retinal pathologies can be there. Optic nerve pathologies, including optic neuritis, optic atrophy, any of those can be there, as well as stroke. Intraoperatively, a block perforation. Nobody knows. I mean, if you inject xylocaine into the vitreous, definitely yes, the cornea is going to be steamy. But if you perforate and you go inside, a double perforation, and inject, the block would be perfect, and you would do a cataract surgery, but final end result may be a retinal hemorrhage or vitreous hemorrhage or something like that. IOL decentrations can occur intraoperatively, but that would not be a clean case, I would say. Intraoperative AION, when the bottle heights are very high and the pressure inside the eye is quite high, and you're working on a very closed cavity, sometimes in labile optic nerves, like a glaucomatous optic nerve or a diabetic person, you can have an intraoperative AION. Also occurs when you are applying significant massage after a block. Now, intraoperative vascular block, we should know that the perfusion pressure of the retinal vein is somewhere around 20-25 millimeters of mercury. And if your pressure intraoperatively goes up to 30 or 40 because of the high bottle height, and sometime when you are not aspirating enough, the pressure increases, something like that, then you can end up in a vascular block. Intraoperative choroidal detachment, suprachoroidal hemorrhage in a mild way, you may not consider. I mean, sometimes just a little harder eye, which you manage, just like we discussed in the beginning. Vitreous hemorrhage intraoperatively can occur because of any other reasons as well. Postoperatively, you can have a choroidal detachment or a delayed suprachoroidal hemorrhage during the first 24 hours. And day one, the anterior segment may look normal, but would be a suboptimal visual recovery because of these problems. High IOP, yes, there can be corneal edema in high IOPs. Sometimes what can happen is high IOPs can cause functional optic nerve damage, and can present with a suboptimal visual acuity. Similar in malignant glaucoma, but that would not be a clean case. Early endophthalmitis, where anterior segment is reasonably clean, but vitritis is there, the patient may complain, and that is something that we have to look at. Vascular block and AION are two other postoperative problems. skipping the delayed post-operative, because we are basically concerned about day one when you are looking at the this thing. What can be done now? Like if there is an astigmatism, you would intraoperatively also probably do a lot of procedures to alleviate the astigmatism, maybe a toric IOL, maybe incision planning, maybe keratotomies, something like that. And glaucoma, preoperatively, many of these glaucomas, whatever damages occur to the optic nerve is permanent and cannot be reversed. But maybe you could do things to control the IOP. You may not use steroids and stuff like that. Floaters, we had one talk on that, so I am not repeating that. Retinal pathologies, it depends on the retinal pathology. Maybe it's a diabetic macular edema or an RVO, or with macular edema or an AMD, you may consider injections. If it is a VMT or a macular hole or something like that, you may require a vitrectomy. Optic nerve diseases, if it is a pit, there are some reversible optic nerve diseases like optic neuritis or optic disc pit with fluid, sensor neural detachment. Those are manageable, but generally optic nerve diseases with atrophy, you cannot do much about it. Block perforations, if you have a suboptimal visual acuity, you look at the retina and you see perforations, you might immediately laser those areas, and depending upon the amount of vitreous hemorrhage, you may consider whether we have to conservatively manage it or do that. Intraoperatively wrong powered IOL, that is a problem. You may have to change the IOL. IOL decentrations or dislocations in the first 24 hours, but that would not be a clean case. When you see in the first postoperative, you would be seeing that. Probably you will have to redo the surgery, or maybe you will have to do a vitrectomy, remove the IOL and put in another IOL. Intra-op AION and vascular block and all, you have to treat according to the usual consensus. AION is generally intraoperatively, maybe you can give some IV methylprednisolone to see whether it is improving. It is a little different from the non-arteritic AION. And choroidal detachment and suprachoroidal hemorrhage. Choroidal detachment, if it is due to wound leak or something like that, basically you have to plug it. Suprachoroidal hemorrhage depends upon the amount of suprachoroidal hemorrhage. If it is mild, you may observe with a reduction of pressure and it may subside. Vitreous hemorrhage also depends upon the amount of vitreous hemorrhage which is there, and we will manage it accordingly. Now, post-op choroidal detachment and suprachoroidal hemorrhage, it's almost equal. I mean, depends upon the amount of that. And high IOP definitely should be managed. Endophthalmitis, vascular block, any other retinal pathology which is developed. I mean, whatever we talked about in intra-op pathology, we have to basically do. Vascular block has to be treated that way. Any other retinal pathology, look whether this is going to be reversible or not, and then plan. Now, counseling of the patient is quite important. Missing a pre-op pathology is a mistake. So you have to basically tell the patient that the cataract was dense and we could not exactly see the pathology, something like that. You have to basically say. Intraoperative complication, we have to be rather honest, and we have to say that only in this tiny minuscule percentage of patients this occurs, and unfortunately it has occurred in you, and we will do whatever it is possible to manage it. Post-op pathologies, definitely you can always say, textbook says this is the percentage. Even intra-op and post-op complications and pathologies, we can basically look at it. End of the counseling has to be very, very nice, otherwise the patient will land up with a lot of problem, a court case and all those things. So we talked that it is a you have to tell the patient about infection, but at the same time you have to talk to the patient positively about how you're going to treat the patient and possibility of vision recovery, etc. Breaking news slowly, firm yet soft and empathetic. And financial transactions is very important. Sometimes what happens, if there is a problem, the doctor gives the money back to the patient, and that can lead to some problems, especially in the court legal side, that because you had a guilt of a mistake, you gave the patient money back. So all those problems are there. I would not go deep into it. Documentation, all these cases are potential legal cases. It will end up in a legal tangle. So each document preoperative and postoperative vision and reasons for visual loss found and documented, and document that you have explained about this to the patient and you have explained all possible management options and the prognosis, and all this has to be well documented. And if you say that these are the problems, we found out the problems, we have counseled the patients of the problems, we told the patient how we are going to manage it, and then if he has not gone through that, it is not our problem. Thank you very much. To conclude, we have to have a robust pre-op evaluation, all efforts to prevent intraoperative problem, vigilant and high index of suspicion for any early post-op pathology. Be available. You have the senior surgeon has to be available for counseling if there is a problem patient, and good documentation, and refer wisely. Even a second opinion can help, because the peers will talk about the same thing. All patients, when there is a problem, they will develop a small mistrust, especially if the doctor is a little junior. There will be a mistrust, and be honest with the patient. Thank you very much.
Thank you, Gopal. We have almost through. Umesh is a wonderful communicator. Yeah, it's basically what I want to say is everything is okay. Everything is okay. The IOL power, everything is okay, and when you don't have any pathology seen there, so the patient has a subtopic, whatever from the normal examination that you have. So what do you do in this case?
Yeah, I think the newer diagnostic equipment will come to your help. For those who don't have, but you can refer it to people who have eye trace. Eye trace actually now measures the corneal wavefront, the lens wavefront, and it equally identifies where the exact problem is. Where we are not able to identify, it identifies. Probably from that standpoint, we can take a call. Apart from that, literally we have not seen. It could be one of the causes where we can identify definitely. What I would add to what Dr. Gopal has said is have a robust consent form in place, and most of the consent forms, with the newer consent forms that we have all the possible implications here, and that should save your skin.